Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to our concluding episode of the Emerging Evidence in Myasthenia Gravis podcast series. I'm Dr. Nick Silvestri, and today we'll explore future directions in MG care, highlighting upcoming diagnostic technologies and the urgent need for harmonized international guidelines. In the next 10 minutes or so, we'll cover what's coming down the pipeline in diagnostic innovation, why standardizing MG care globally is more urgent than ever, highlights from the American Academy of Neurology 2025 meeting that signal where the field is heading, and what this all means for you and for your patients. If you're a clinician managing MG, this episode will help prepare you for what's next and start adapting today. So where are we now? Myasthenia gravis is no longer the therapeutic backwater it once was. The last 5 years have brought targeted biologics, serotype-specific care, better understanding of disease subtypes, and growing real-world evidence for tailored treatment plans. But the diagnostic and care landscape is still fragmented, especially globally. Access, protocols, and practice patterns differ dramatically between centers, countries, and even clinicians within the same hospital. As we enter a new era of precision medicine, our collective goal must be this: early diagnosis, targeted treatment, and standardized pathways for all patients, regardless of where they live or who they see. Let's first start with diagnostics. AAN 2025 featured some exciting updates in this space. These innovations aim to improve the speed of diagnosis, the sensitivity for seronegative cases, and accessibility even outside of tertiary centers. Here are diagnostic developments to watch. Number 1, next-generation antibody testing. While standard ELISA-based testing for acetylcholine receptor in MuSK remains the norm, live cell-based assays, or CBAs, are now widely regarded as the new gold standard, and they allow early detection of low-affinity antibodies, LRP4 antibodies, agrin antibodies, and perhaps other emerging targets. This is especially relevant for underserved or atypical presentations like isolated bulbar weakness or refractory ocular MG. Even broader access to multiplex CBA panels in the near future, likely bundled into standard myasthenia gravis diagnostic kits, should be expected. Let's now talk about digital electrophysiology and AI-augmented analysis. So classic single-fiber EMG and repetitive nerve stimulation are powerful but resource-intensive. Let's move on to MG biomarkers beyond antibodies. This is a frontier still in development, but gaining traction. That is the identification of MG disease activity biomarkers. In the future, these biomarkers could help clinicians predict flares, adjust therapy cycles, or even monitor treatment response without full clinical assessment. While still experimental, this is an area of major interest. Despite all the progress, there's a problem in terms of guidelines. There's a case for global harmonization, and that is because MG care varies wildly. Let's take 3 quick examples. In some countries, complement inhibitors are first line for moderate to severe acetylcholine receptor positive disease. In others, they're unavailable or used only after multiple failed therapies. Or how about serotype testing? It's routine in major academic centers, but rarely performed in smaller clinics, even in developed health systems. Or finally, steroid tapering protocols differ between the MGFA, EAN, and country-specific guidelines. This inconsistency creates confusion for clinicians, disparities for patients, and inefficiencies for healthcare systems. And that's why there's a growing movement, which was reflected at AAN 2025, to unify global MG care networks. A working group led by representatives from the Myasthenia Gravis Foundation of America, or MGFA, the European Academy of Neurology, or EAN, and the Japanese Neurological Society is currently drafting a new consensus guideline. Early objectives include, first, standardizing the definition of treatment-resistant MG, next, providing evidence-based pathways for initiating biologics, outlining core diagnostics, so what every patient anywhere should receive, and finally, establishing minimum standards for follow-up monitoring. These are expected to be released in early 2026 and could change how MG is managed globally. So what's the real-world impact? What does this mean for practice? What can we take back to our own clinics today? Number one, don't wait for perfection. While we await formal guidelines, there's enough consensus already to begin standardizing your local protocols. You can start by ensuring that all newly diagnosed MG patients receive AChR and possibly MuSK and LRP4 testing, document antibody subtype and adjusting treatment plans accordingly, establishing a steroid tapering strategy with regular monitoring of MG-ADL, and finally using validated tools like MG-ADL, QMG, or MG-QOL15R to track progress. You can think globally but practice locally. Understand where your local care gaps are. For example, if electrophysiology is limited, consider referring sooner or using telehealth. These consultations can be quite helpful, such as with neuromuscular specialists. You can advocate with hospital labs to start adopting higher sensitivity assays, and you can collaborate with pharmacists and payers to ensure equitable access to new therapies. You can also use networks. You should leverage MG networks, such as the International MG Patient Registry, MGNet, or Regain long-term extension studies to get insights, contribute data, and stay connected with evolving standards. So let's look ahead. What does the future hold? Here's where the landscape of myasthenia gravis could look in the next 5 years. All patients screened at first neurologic contact with multiplex antibody panels, AI-assisted single-fiber EMG in outpatient neurology clinics, standardized global care pathways accessible via mobile apps, biomarker-guided therapy reducing unnecessary immunosuppression, and MG clinics functioning more like an IBD or RA models with proactive, personalized care teams. And beyond that, possibly antigen-specific tolerance therapies and vaccines to reset the immune response, as well as non-invasive tools to track treatment response at home. The ultimate goal, turning MG into a condition that is rapidly diagnosed, precisely treated, and consistently well managed anywhere in the world. So let's bring it all together. Let's summarize today's takeaways. MG diagnostics are evolving rapidly with expanding antibody panels, portable EMG tools, and AI support on the horizon. Global guideline harmonization is underway, aiming to unify diagnostics, treatment timing, and long-term follow-up. Clinicians can begin adopting standard practices today using accessible resources, and equity and access must remain front of mind, especially as biologics and specialized diagnostics become more commonly used. The future of MG care is precision-based, proactive, and personalized, and it's closer than you think. Thank you for joining us for this 4-part podcast series in emerging evidence in myasthenia gravis. We've traveled from diagnosis to cutting-edge therapy, from antibody subtypes to global vision, and one thing is clear: the momentum in MG is real. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access downloadable slides, as well as other topic segments and case scenarios. Together, we can close the gaps, raise standards, and ensure every MG patient, wherever they live, receives the highest quality of care. Until next time, stay curious, stay connected, and keep leading with purpose. Thank you.